This next short video will be covering the next portions of this slide: torticollis, stenosis, and Facet syndrome. Before we dive into torticollis, just a quick note. I hope by now you guys are beginning to realize, as we've worked through the body, that oftentimes the issues can be caused because of many types of different pathological conditions. Sometimes you're born with it. Sometimes it develops over time. Sometimes it's a nerve problem. Sometimes it's a muscle problem. Sometimes it's an injury that occurs. Sometimes it's genetics. The same thing is going to be true in concerning the spine. What causes spinal issues? Well, it could be all sorts of things. It depends on the initial moment and when it started, and it's the job of the clinician to begin to piece a lot of that together, realizing that it definitely can happen where sometimes it's just a genetic condition that may or may not have taken a while to show up. So today, with this video here, we're going to hit a couple different causes of that in torticollis, where it can be genetic, it can be something that just happens, or it can be because of some type of an injury. So as we get into that, we're going to see that. Just kind of remember this slide as we go through the rest of our spinal issues, where we can have all sorts of things which contribute to our spinal problems. Which brings us to torticollis. So what is it? Torticollis is a condition where we have a tightening of a muscle, the sternocleidomastoid muscle. If you remember from your anatomy, it's going to run from that mastoid process down to our sternum, right, and our clavicle. So we're going to have a muscle that runs right down that way, and if you turn your head and you contract to the side just right, you can usually get yours to pop on out. So the treatment with all of our torticollis is going to be some gentle stretching, and depending on the severity of the torticollis, we are going to move further into be more aggressive, right? So let's look at a couple basic statistics about torticollis, and then we'll talk about some different types of torticollis that we can develop or have, and then we'll move through those, okay? So some background, 3 in every 10,000, so that's not going to be uncommon. It's likely that you will hear of someone, if not yourself, know of someone that has to deal with torticollis at some point in their life. It affects more women. Head turning is the most frequent symptom. Remember, it's that sternocleidomastoid. So sternocleidomastoid does lateral, unilaterally, it does lateral flexion to that side, and it turns the chin away. So think about that for a second. It does lateral flexion to the same side, and it's going to pull that chin away from that side. So you can do that, and you can have your sternocleidomastoid actually pop out. Oftentimes when people have a torticollis, they don't actually know that they're having a problem, and then it can lead to some problems, and we'll kind of look at some of those. So our types of torticollis, we're going to have that congenital, right? The one that happens. We're going to have idiopathic. Remember, idiopathic means we don't know why. It just comes. Spasmatic, meaning it's going to tighten. And then we have an acute type. So we're going to go ahead and roll through these 3 types so that you can see each one and how each one is inherently similar, but they each have some distinctive differences. So our congenital torticollis. Again, we're talking about that sternocleidomastoid muscle. It usually happens just after birth. So the parents are going to notice, hey, the baby is always on one side. They're always on one side. When they take them into the doctor to be evaluated, the doctor is going to feel in that sternocleidomastoid for, they call it an olive. I've never felt one. This is obviously not my specialty. However, the clinicians that I looked into, they talked about this olive, that they can feel it, and it's going to be in the middle of the muscle. That muscle is going to be tight, so when the doctor goes to pull it away, they're going to pull their body with it. You can stretch it out. And then the theory as to why it may occur, they talked about reduced blood flow reduced blood flow due to positioning in the vagina while the baby is in utero. So here's kind of an image of that. This one is going to be just prior to them entering the birth canal, right? But there's going to be this position of comfort where the baby is more on one side than the other, and you can see how they're tilted. So they talked about how this sternocleidomastoid gets really comfortable in a shortened position. And so when the baby comes out, they are stuck there. It didn't develop in a lengthened position, and they're going to have that olive feature where they feel a lump in that muscle in the baby. So here's an image. Remember, the baby's skulls are going to be fairly soft when they're little. So a baby that spends a lot of their time on one side of their head, we're going to begin to see some malformation of that side. So you can notice here, well, we'll start here. This is a nice, fairly round head. And then we look at this one. You can notice right away, this is a nice convex side, while this is fairly flat. It's flat. It's almost concave on this side. This is going to be a baby that had that congenital torticollis where they spent all of their time on this side of their head. So as a new parent, this is something to just evaluate for. Just make sure that your baby's comfortable going to both sides, right? They can turn to their left, they can turn to their right, and then you can position them as they sleep, as they go throughout their life. Okay, so the next one is going to be this idiopathic spasmatic torticollis. So we don't know why it happens. That's what idiopathic means. It's an injury without origin. And then spasmatic meaning the sternocleidomastoid is going to just have a contraction. It's an uncontrolled contraction. So you can see that there's several different types. It depends on if it's affecting both sides or if it's affecting just one side, how hard it's affecting. This is going to be a common thing. So remember, they're going to be laterally flexed to the same side, and then chin is tilted away from that sternocleidomastoid. That's the action, right? You can see this muscle here. That is a very prominent one. If it's affecting both sides, right, we might have this Torticollis. Often there will be a family history associated with this idiopathic spasmatic torticollis. And you might pay attention because maybe the person doesn't realize that they are tilting. These are going to be pretty drastic examples here. I mean, these people, you can see it. But maybe someone is only comfortable going to one side and they really don't like to go out of that side. And so that would be someone where you might evaluate for this idiopathic spasmatic torticollis, where maybe certain time periods or whatever, they only like to just tilt to that one side, and you might notice that in that muscle. So then our last one is an acute torticollis. So this is usually the result of some type of an injury or sleeping in an awkward position. I've dealt with several of these, and as a clinician, it's very likely that you will have someone come in with this. In fact, I have experienced an acute torticollis due to a sleeping position, which I think resulted in a pinched nerve. Dr. Johnson actually put a note down here in his slides about a woman he treated on this wild mouse ride, where you whip the neck just right, it results in torticollis, so a tightening of that sternocleidomastoid that is uncontrollable, and it takes time to work out. So let's go ahead and look at the treatment. So with each one of these, they're actually each going to be treated in similar types of fashions. The main thing being to relax those muscles and perform some stretching. We've already talked about this helmet. This helmet's more for the shape. It's not actually going to be a treatment for the torticollis. So the treatment should be focused on that sternocleidomastoid, which is contracted uncontrollably. And so we're going to do some stretching. We might use an injection to relax that muscle, right? There's some medications that can do this. In my experience, I used a lot of this stretching exercise, especially when it was that acute torticollis, some heat, some massage, and some stretching. And I found that usually within a time period of a week, most people were pretty good to go after that. If it's that idiopathic spasmatic torticollis, maybe it's something that just recurrently keeps coming back over and over and over. And so we might be looking more in this area. And with those babies, I think we're definitely going to start with this stretching. We're going to try to just relax those muscles and see if we can fix this conservatively. Here's some examples of those stretching exercises. Actually, when you go into the doctors when you have a baby, they often perform these stretching exercises to make sure that they feel like the baby can move. So as they do those, you can watch those, and you can actually help perform those on your children when they're babies. They will not like it, but you can go ahead and do that. And I think that's what we'll say about that. So those are some examples of those torticollises, and each one how it's a little different. Okay, so now we'll look at this stenosis. We've mentioned this actually with the myelopathy. A stenosis is simply a narrowing of a canal. So we have lots of stenoses that are potentially possible in the vertebral column, right? We can have a stenosis of that central canal. We can have a stenosis of our intervertebral foramen. We can have a stenosis at the foramen magna. There's lots of potential stenoses that may exist up and down the vertebral column. Those stenoses can come from many different possible regions. As I mentioned up above, right? There's lots of possibilities that contribute to a stenosis. We may have a disc which has herniated or extruded, or maybe we have some degenerative disc disease. We may have some osteophyte formation on a bone. We may have an enlarged, what do we have here? Enlarged facet joint due to inflammation, so like a facet joint syndrome, and so that joint has swelled up, so now we have a stenosis. The reason stenoses, we talk about them here in the spinal column, as I move off of that, is because when we have a stenosis in a vertebrae, it's often going to pinch on the spinal cord, which is going to cause problems. So pause for a moment, think about this, right? Think about a stenosis, and now begin to think about the signs and symptoms that you might see or hear about if someone has a stenosis, right? The pain can be unilateral, bilateral, depending on where the stenosis is. It's usually going to increase on extension. It's going to decrease with flexion. If it's unilateral, usually one direction on lateral flexion will increase the symptoms, and leaning away will decrease the symptoms. And then on an MRI, we're going to see a narrowing of this canal. Kind of an interesting story as a clinician to keep this clinically oriented. In football players, it is, 50, 60% of football players and young football players between the ages of 15 to 25, they actually experience cervical stenosis in the central canal. And you think about that for a second, you should think, oh, maybe that kind of makes sense. This is going to be a group of people that work their necks out to extreme amounts. They usually have a helmet on. They're experiencing blows in the direction laterally, forward, backwards, right? And now think about your Wolff's Law. If we constantly are stressing the bones in the neck, those bones are going to grow and they're going to get bigger, right? According to Wolff's Law. It therefore begins to make sense that we are going to see some stenosing in that neck region of these young football players. As a result, football players are more likely than the average population of their same age group to experience neurological symptoms due to a stenosis. So I had some interesting clinical experiences due to that, and especially in one young athlete. So kind of a cool application of that stenosis. You can see here over several regions, we're going to have that stenosis. The treatment for a stenosis is to get the person out of stenosing. Take them out of extension. If they are that football player, unfortunately, oftentimes it means they have to rest in order to get those neurological symptoms down. We might have to do some surgery and go in and actually widen the canal. It may depend, and then obviously we have some rehab that is going to contribute to our strength and our stability. The final one that we're going to cover for this video is our facet joint syndrome. So I've mentioned about our facets. So now you're thinking, okay, I know what a facet is. Now, what is the problem that may be associated with a facet joint? Remember, this is our synovial joint in the spine, the one that's the main cause of the movement. So because of that, we may experience some definite arthritis or other similar types of joint problems here in the facets. The articular cartilage may begin to break down. Because the articular cartilage breaks down, we may begin to get some osteophytes that begin to develop. And now we're going to see limited range of motion, painful movement that's going to occur. And this is where knowing those facet joint movements, right? So in the lumbar region, remember, we're going to have a lot of that flexion and extension. This is where that's going to come in handy. Where do they have the most pain? During flexion and extension, during lateral flexion, during rotations. When does it hurt the most? This is a common clinical problem, guys. It's something that you will most likely see as you participate in your clinical medicine, this facet joint syndrome. So the diagnosis, they say here it's difficult, and that's because we have so many potential problems at the back with pain. And so really they're going to take an x-ray. They're going to see some of this osteophyte formation. They're going to realize that not a lot of the other treatments that they've been doing is going to work. And so they're going to begin to come to a facet joint syndrome through a process of elimination. So the treatment, we're going to do, we always have the option to strengthen, right? We always have the option to stretch and strengthen. Especially in today's society, it's something that needs more and more attention, where we become more and more sedentary in our day-to-day lives. We always are going to have this option. We have an image here of a facet joint injection. This is something that can be used in conjunction with our exercises, right? Where they go in and they actually inject some Synvin, some synovial fluid, to help this joint actually do its job. I actually think we have some cool ultrasound guided injections here where you can actually see the needle going into that facet joint. And so kind of a cool thing there. We're going to use that in conjunction very often with this therapeutic exercise. There's obviously options for surgery where they can go in and shave down some of those osteophytes. I actually have no idea if they have ever done like a replacement of this joint. I would doubt it, but that would be kind of interesting to look up. Maybe I'll do that. So there is some options for the treatment of this facet joint, and it just depends on the severity for the person. So that wraps up this video covering facet joint problems, stenoses, and torticollis.